when patients relapse, either after frontline therapy or after autologous stem cell transplant, I generally think of patients in kind of two main buckets. The first bucket is patients that have a great performance status, blood counts are pretty good, have good organ function. So these are patients that really are great candidates for an aggressive approach when they relapse, either after transplant or after frontline therapy. Those patients, I still use combination approaches. And that would mean some combination chemotherapy that hopefully uses different drugs than they were exposed to either in the transplant or in the frontline setting. And I'll use an example. If a patient received CHOP chemotherapy in the frontline, and then they receive ICE chemotherapy and ICE didn't work, I would switch to DAP, or I would switch to GemOx, or I might switch to a methotrexate-based regimen. So I'm thinking of, this patient has good performance status, they're still very healthy, and what is a combination chemotherapy regimen that could potentially work, that'll kill these cells that didn't respond to traditional chemotherapy. Ideally, if they're pre-transplant, I'm again trying to get them to a place, a good remission, where I can get them to autologous transplant. If they're relapsing after an auto transplant, I'm trying to control that disease to get them to a place where they might tolerate allogeneic transplant or potentially go on to some maintenance therapy or something to try to control their disease long term. Now, the other bucket of patients are patients who either are too old meaning, I hate to use the word old because I think old is just age, but I should say patients that have poor performance status, they're bedbound, kidney function isn't very good, they have difficulties with their heart function, and these are patients that even if I can get them into a remission, probably are not going to tolerate a stem cell transplant. Now those patients, I'm looking for something that is not too toxic and is going to give me a long progression-free survival as possible. So then I'm thinking about novel targeted drugs, potentially immune-based drugs, biologic drugs that patients can tolerate, is not going to affect organ function, and can give me a long progression-free survival as possible. And it's the old kind of cliche, I'm really trying to maximize their quality of life. And when I say cliche, what we don't ever want to do is have a treatment that's worse than the disease. So in a patient who I can't give aggressive chemotherapy for, I'm really looking at something that's mild and is going to control that disease as long as possible.